Hi, welcome to Georgia Bone and Joint. I am your host, Dr. Trevor Turner, MD, RMSK, and I'm going to be presenting this webinar for you today on how to avoid a knee replacement for 15 years. So with that being said, I'm going to switch over to our PowerPoint and we'll get going. All right. This is brought to you by the Center for Orthobiologics. Got the laser pointer going. Well, let's start moving. Let's discuss a little bit of the problem that's in front of us. Osteoarthritis is the most common joint disorder in the United States, and knee osteoarthritis prevalence in the US is up to 33.6%, or almost a third of our population, meaning it's affecting over 12 million people and usually affects more women than men. The incidence does increase with age and with people that are higher than average weight. And we know that every pound above the ideal body weight increases the amount of force on the knee by a factor of 4. But the inverse is also true, which means losing even 1 pound can reduce the amount of force across the knee by a factor of 4. Unfortunately, this is not just a disease of the elderly anymore in the US. In fact, we're seeing younger and younger people in their 40s and early 50s being affected by it compared to trends in the past. We used to think this was just a disease of wear and tear, but now we're starting to realize that we didn't know as much as we thought we did. Osteoarthritis is, in fact, a complex interplay of a loss of integrity of the joint, of your genetics, of inflammation, of different kinds of mechanical forces. And what I highlighted in particular is cell and biochemical processes, as this is going to be extremely relevant to the way that we talk about treating this disease in a totally new way. On the right is a graph that comes out of the Journal of Rheumatology. What you'll see on the bottom axis is the year, and what you'll see on this axis up and down is the number of joint replacements done a year. TKA stands for total knee arthroplasty, which is the abbreviation that doctors commonly use for a knee replacement. So this orange line is trending upwards and upwards and upwards as time goes on. Importantly, right now in 2020, we do a little bit more than 1 million knee replacements a year. But as younger and younger people suffer from the disease of arthritis of the knee, as the population continues to gain weight, we're finding that our need for joint replacements is going up and up and up. So that within even 10 years, we'll almost double the number of knee replacements that need to be done in our country every single year. And by 2040, that estimate is to be over 3 times as much, even close to 3.5 million joint replacements a year. The problem with that, we don't have enough hospitals and surgeons to even do that many. And so people debate on how we're supposed to solve this problem. Now, you may know some of the symptoms if you've had them yourself. Common symptoms of knee arthritis involves pain around the joint, decrease in the range of motion with bending the knee, either in flexion and extension, meaning straightening the knee or bending it back down, or in rotation. Grinding or popping sounds that your doctor may call crepitus when you're in the office. Weakness of these surrounding muscles, which is incredibly important. So you see these strong quadriceps muscles on the front of the thigh here that help straighten the knee, the hamstring muscles that help bend the knee and attach down beneath the joint, and then also the calf muscles coming up and attaching just above. Swelling, locking, or a sensation that the knee starts to give way. Stiffness, especially within the first 30 minutes of waking up or getting out of bed in the morning, or pronounced stiffness after sitting for a prolonged period of time in a chair or maybe even on a long drive, or difficulty with climbing up or down stairs or walking as much as people want. One of the reasons I wanted to show this slide is that arthritis of the knee is really a whole joint disease. It's not just as simple as losing some cartilage. And so these structures, like the ligaments and the soft tissue and the muscles and the tendons that attach around the outside of the joint capsule are also critical for maintaining good joint health. So you may be aware, have tried some of these treatments on your own. We mentioned the benefit of weight loss, reducing the amount of force across the knee. Some people may give up their favorite hobbies, like running, and trade them for lower impact activities like yoga, biking, or swimming. Bracing seems to help people in the short term, but we really don't have great evidence that it helps people in the long term or that there's one brace that is vastly superior to all the others. Physical therapy is often helpful in the very early stages of the disease and should probably be continued as a home exercise program. People use TENS units, which apply small electrical signals to help treat some of the pain fibers that transmit pain when the joint breaks down. You may have tried some of these medicines and maybe taken more than you really wanted to. Unfortunately, the risk of non-steroid anti-inflammatories are that they can cause ulcers in the stomach lining or even increase your risk for heart attack or stroke, depending on your other medical problems, which is not insignificant. Finally, there's injections, which for years were done with steroids, which is this yellow substance you see here. Although we now have pretty good evidence that steroids are actually toxic to the cartilage cells and the tendons of the joint, begging the question, should we really be giving them to patients in the first place? Finally, there's arthroscopy, which is not a knee replacement, but involves the use of a small camera and then some tools that are used to otherwise clean out the knee, as some people will describe it. However, unless you have a frankly unstable meniscus tear or other problem that contributes to mechanical symptoms in the knee, sometimes knee scopes don't always lead us to the path or to the benefit that we're looking for in the long term. Let's talk a little bit about stages of arthritis. You see a normal, healthy looking knee over here on the left. Here's the joint capsule and the bone, and this cartilage is this nice soft tissue that sits on the edge of the bone right here. As knee arthritis begins, we start to develop these small fragments within the cartilage, and the bone, which was healthy, is now starting to turn harder, and we may even develop swelling on the inside of the bone. As the ligaments and the soft tissue and capsule become looser, they lose some of their integrity, and we begin the formation of these bony spurs. The ends of the cartilage is otherwise becoming tougher and harder. As the joint space continues to narrow and the spurs become larger, some of these inside portions of the bone will wall off and become cysts. They no longer contain any healthy bone tissue inside of them, and eventually the joint itself will collapse, leading to the dreaded bone on bone that patients cite when they come into the clinic. Let's talk a little bit about how x-rays look. When doctors assess grading of arthritis, we use a system that's been around for a long time called the Kellgren-Lawrence grading scale. The grades go from 0 to 4, 0 being normal. Grade 1 has very, very minor changes of tiny, tiny narrowing or spurs that just may be beginning to form, but to the untrained eye may not really see very much there. By grade 2, we're starting to form some small bony spurs that are now visible to even the untrained observer, but the joint space is not significantly narrow yet. As we progress towards moderate arthritis, you can clearly see narrowing of the joint space here with larger formation of bony spurs, but there's still space if you had to look between the two edges of the bones. By the time you get to grade 4, the joint space is severely reduced, and these are the patients that we typically send for knee replacement. Let's talk about changes on MRI. Doctors don't routinely use MRIs to manage osteoarthritis of the knee unless something complicated is going on or otherwise makes us suspect that something else is happening. Healthy bone in this MRI sequence looks dark gray, like this. This large circle here is surrounding disease in the underlying what we call subchondral bone. I'll show you another picture of that in just a second. But part of the reason this is so important is that this underlying bone nourishes critical parts of the cartilage that covers the joint. So disease in this underlying bone or a cyst that forms in the underlying bone like this can correlate very well with number one, how badly patients hurt, and number two, how severely their disease has progressed. In a landmark paper, Dr. Felipe Hernigo, who is otherwise called the godfather of orthobiologics and an orthopedic surgeon in Paris, France, published a study where he compared injections into the subchondral bone versus intra-articular, meaning injections into the joint, of bone marrow derived mesenchymal stem cells in people who have knee arthritis on both sides. In this landmark study, Dr. Hernigo took the knees of 60 patients for a total of 120 knees. He derived cells from the bone marrow and had very specific measurements about how many cells he obtained. Half of them were used to treat inside of the bone, and the other half were used just to treat inside of the knee joint themselves. They followed these patients for a total of 15 years, had MRI follow-up as well as notes about whether or not they progressed to surgery. Notably, with the patients that had the subchondral cells, or otherwise the patients who got the injections put in the underlying bone that nourishes the cartilage, only 20% of those patients ended up having a knee replacement 15 years out. But 70% of those patients ended up having a knee replacement on the side where they just got the injection into the joint. And of the 18 patients who had no surgery at all on either side, all of them said that the knee felt better on the side where they had the injection into the bone. This is a pretty wordy slide, so let's just summarize real quick. 120 knees of 60 patients. Half got injections into the subchondral bone, which is what you see right here. This critical part of the bone that sits right next to and nourishes this layer of cartilage, which sits right here. The other half had injections out here into the knee joint, but not into the bone. For those that got the injections in the bone, the MRI they took 2 years out looked better. Only 20% of those that got injections in the bone had a knee replacement 15 years later. But 70% of those who had injections just into the joint had their knee replaced after 15 years. What's the takeaway here? People who are trying to truly modify the progression of disease for knee arthritis and who've trained at an elite level to perform these injections safely should be injecting bone marrow derived mesenchymal stem cells into the subchondral bone to give patients the best outcomes over time. Let's talk a little bit about what this procedure is like. When a patient is a good candidate for a procedure such as this, they come in to the operating room or to the ambulatory surgery center for a same-day outpatient procedure. That patient receives numbing medicine on the surface of the bone. What I usually hear from patients is, I've heard that getting my bone marrow sampled is terrifying and is extremely painful. I will tell you that of the patients for whom we've performed this procedure, I have never had a single patient tell me that they could feel the needle go into their bone marrow, nor have I had them say afterwards that they had significant pain or complication from the area where the bone marrow was sampled. Likely that's for a few reasons. One is our custom anesthetic mix, which is very powerful. And two is because all of the needles we use to derive cells from the bone marrow are guided by an ultrasound or an X-ray, meaning we can be incredibly precise and accurate. Critical to Dr. Hernigo's study is being able to sterilely process these cells and to measure them so that we know that we're getting a high enough number to give the patient the outstanding results that he achieved in his study. When you come to a place like Georgia Bone and Joint, everything is sterilely processed in what's called an ISO 5 hood, which means even particulates in the air are removed in the area where any of the samples of sterile bone marrow is prepped or processed in a same-day outpatient procedure. A very tiny sample before and after centrifugation, which is the process by which we concentrate the cells before putting them back into the knee, is measured in a device like this, among others. This is a hemoanalyzer, which allows us to look at different fractions of cells within the sample that we obtain. Once we are confident that we have a high enough concentration of cells to give the patient a good lasting procedure, we then proceed to the delivery system. Here is an example of the needle that is used to draw the cells out of the bone marrow. And once the sample has been prepped, they look similar to this inside of the syringe. We then use a state-of-the-art X-ray that revolves around the patient's body, that's otherwise called a fluoroscope, to take pictures of the precise spots on the joint of the knee where it is diseased in order to deliver those cells most effectively to the area that they are needed the most. Patients are often worried that putting a needle inside of the joint or the bone is going to be extremely painful. However, at Georgia Bone and Joint, we have a fantastic team of regional anesthesia providers that are able to give nerve blocks before the procedure so that patients don't feel anything that goes to the inside of the joint. Remember earlier when we talked a little bit about bone marrow lesions or the sickness that exists within the bone just next to the cartilage layer? Well, this is how they look on the MRI. So during a procedure, a picture of the patient's MRI is pulled up into the procedure room or operating room, and we are able to then use this picture to correlate with the X-ray where these needles can then be placed for maximum effect. Most patients receive sedation for this procedure, but few, if any of them, need any general anesthesia, meaning we're able to avoid some of the risks that are otherwise associated with surgery. Finally, many patients have had bad experiences with rehab in the past, with some of them even telling me all I did was show up at a gym and be put on a bike for 10 minutes and billed my insurance for a large amount of money. That is not the type of attention to detail and care that our patients get when they rehab at Georgia Bone and Joint. We use the modern Delphi tourniquet system, which was developed by Owens Recovery Science, in order to get our patients' bones, ligaments, and tendons healing faster than they could at an otherwise more conventional physical therapy. Additionally, for patients who prefer a concierge type experience that is integrated to their laptop or web portal, we use an outpatient digital rehabilitation service called AMP Recover. This app can be found on the App Store and downloaded to a patient's iPhone or tablet as well. It is also supported by Droid, and this can help answer questions and guide the patient through critical places of their rehab. Thank you very much for joining me today. These are my references, so you may see that this is well evidenced based literature that is published that you may verify yourself. That is the end of this presentation. Again, I'm your host, Dr. Trevor Turner, MD, RMSK, as a director of the Center for Orthobiologics at Georgia Bone and Joint. If you have questions or wonder whether or not you're an appropriate candidate for a procedure like this, please feel free to give us a call at 770-502-2175 or book online at georgiaboneandjoint.org/book appointment. Thanks so much.